Everyone's familiar with the clinical features of asthma: recurrent bouts of shortness of breath, chest tightness, and wheezing, often associated with coughing. The thing to keep in mind when treating asthma is that you're combating two separate processes. First, there's the widespread reversible narrowing of the bronchial airways, with increased bronchial responsiveness to inhaled stimuli. But on top of that, you've got lymphocytic and eosinophilic inflammation of the bronchial mucosa. Therefore, when managing chronic asthma, you need to consider both bronchodilator therapy, such as an inhaled beta agonist, and anti-inflammatory therapy, such as an inhaled steroid. The setting of a parade is perfect because you'll soon see that long-term asthma management involves incrementally stepping up the number and dosages of medications until the patient achieves control. So as the parade marches along, we're going to outline the therapy for mild intermittent asthma and work our way up to therapies for controlling more severe persistent asthma, as well as a few alternative agents that may be helpful in special situations. Classic allergic asthma is mediated by IgE, produced in response to exposure to foreign antigens, like from dust, dander, or pollen. Once produced, IgE binds to high-affinity receptors on mast cells in the airway mucosa, so when you're re-exposed to these same allergens, bam, it triggers the mast cell degranulation, as well as the synthesis and release of other mediators. You've got histamine, tryptases, leukotrienes, prostaglandins. These all cause local smooth muscle contraction and vascular leakage. Sympathomimetics are your go-to agents to rapidly counter this bronchoconstriction. Recall from our sympathetic summer camp sketch that beta agonists have two receptors to choose from. Beta 1, that rousing beta 1 bugler, activates the heart. Beta 2, that big dilated beta 2 tuba player, relaxes smooth muscle. Therefore, beta 2 selective agonist drugs, particularly albuterol, are the most widely used sympathomimetic agents for treating the bronchoconstriction of asthma. Agents available by inhalation that are selective for beta 2 are preferred because, compared to non-selective beta activators, they provide equivalent bronchodilation with less cardiac stimulation. To remind you of that rol suffix common to many of the beta 2 selective agonists, including albuterol, metaproterenol, and perbuterol, we've included our recurring rol roll call sheet held by the band leader. Another beta 2 agonist available is terbutaline. We've seen it before as a smooth muscle relaxant used to prevent preterm labor, kind of like putting a do not disturb sign on the uterus, if you will. Well, the same mechanism can also be useful when managing the bronchoconstriction triggered during an acute asthma exacerbation. Albuterol and the rest of the beta 2 agonists are available as metered dose inhalers. After given by inhalation, these short-acting beta 2 agonists, or SABAs, cause maximal bronchodilation within 15 minutes and persisting for 3 to 4 hours. These are your acute relievers of asthma symptoms, your rescue inhalers. In mild asthma, symptoms occur only intermittently on exposure to allergens or exercise or after a URI. More severe forms of asthma are associated with more frequent and severe symptoms, especially at night. If uncontrolled, chronic airway constriction is accompanied by remodeling and thickening of the bronchial wall, as well as hyperplasia of the bronchial vasculature, smooth muscle, secretory glands, and goblet cells. Long-term management, therefore, is crucial for preventing chronic, irreversible loss of pulmonary function. A stepwise approach to therapy is used, in which the dose or number of medications are increased as necessary. If the asthma is not well controlled, therapy should be stepped up. Let's go through a few of the steps you can use. In patients with persistent symptoms, low-dose inhaled corticosteroids can be added to their regimen. The moon face is our recurring symbol for glucocorticoids because it should evoke an image of the moon phases that can occur in Cushing's disease, as well as with long-term corticosteroid use. Steroids do not relax airway smooth muscle directly, however, so how do they help? Well, after the immediate inflammation of an acute attack, There's a delayed response involving an influx of inflammatory cells into the bronchial mucosa. The cytokines that are produced by these infiltrating leukocytes attract more cells, and they stimulate mucus production. Corticosteroids inhibit the ongoing production of these inflammatory mediators by lymphocytes and mast cells. See how we've made the glucocorticoid moon eclipsing an inflammatory sun? Whenever a test question emphasized blocking the inflammation and cellular infiltration associated with asthma, steroids are your first-line agents. Think of steroid inhalers as your daily maintenance inhaler or controller inhaler. When taken regularly, corticosteroids reduce bronchial hyperreactivity and reduce the frequency of exacerbations. Inhaled corticosteroids such as beclomethasone, budesonide, and fluticasone are delivered straight to the airways with minimal systemic absorption. Inhalation, therefore, avoids the systemic adverse effects of corticosteroid therapy. However, one side effect to keep in mind is oropharyngeal candidiasis. Remember that the Canadian flag is our recurring sketchy symbol for Candida, and nothing says Canada quite like an oropharyngeal Candida snow cone. This is easily treated with topical clomitrazole, and the risk of this complication can be reduced by having the patient gargle water and spit after each inhaled treatment. An alternative agent that can be added to a patient's regimen is a leukotriene inhibitor. Leukotrienes result from the action of 5-lipoxygenase, or LOX, on arachidonic acid, and are synthesized by numerous inflammatory cells in the airways, including eosinophils, mast cells, macrophages. At Sketchy, we abbreviate that ubiquitous precursor molecule arachidonic acid as AA, and in this sketch, it's depicted on the side of the truck, the AA Lacrosse League. You remember arachidonic acid, right? It was first introduced as the precursor benchwarmers converted by Coach Cox into various active players out on the baseball diamond. In other words, within platelets and the vascular endothelium, cyclooxygenase, or COX, was responsible for converting arachidonic acid into various prostanoids, including thromboxane, prostacyclin, and inflammatory prostaglandins. Well, it turns out arachidonic acid has two choices: go down the COX pathway or go down the LOX pathway. Instead of Coach Cox, we're highlighting lipoxygenase, or Coach LOX, the head coach of the champion lacrosse team. The products of lipoxygenase, leukotrienes, are important regulators of inflammation and immunity, and in this sketch, the leukotrienes will be represented by the lacrosse players decked out in their pro-inflammatory jerseys. We've also highlighted the specific leukotriene subtypes, LTB4, C4, D4, and E4. LTB4 is a potent chemoattractant for numerous inflammatory and immune cells, including neutrophils. Just think of lacrosse player B here, who's fallen off the truck bed, attracting the attention of our recurring neutrophil first responders. The warning is right there on the truck, though. I mean, what was she expecting? The other leukotrienes, particularly C and D, are potent bronchoconstrictors and cause increased vascular permeability and mucus secretion in the airways. Hence, their lacrosse sticks resemble bronchi, leading to a pair of lungs. As they grasp onto those handles that connect to the lung-shaped nets, imagine leukotrienes clamping down on those airways. Although they remain less effective than inhaled corticosteroids, leukotriene inhibitors can be used clinically in mild or moderate asthma. There are two approaches to interrupting the leukotriene pathway. The first is direct inhibition of the binding of the most potent bronchoconstrictor, leukotriene D4, to its receptor, the cis-LT1 receptor. And if leukotriene D4 is a lacrosse player, the cis-LT1 receptor is a lacrosse goal, of course. These LTD4 receptor antagonists, Xavier-Lucast and Montelukast, will be represented by Monty here broadcasting live from the parade. And notice, doink, he's directly blocking leukotriene D4 from scoring a goal in that receptor. As a little extra reminder that Montelukast and Xavier-Lucast help dilate airways, Monty is wearing a floppy, dilated pulmonary scarf during the broadcast. LTD4 receptor antagonists have been shown to effectively reduce the frequency of asthma exacerbations, though their ability to dilate airways and reduce bronchial reactivity is less marked than with inhaled steroids. Their main advantage is that they are taken orally, so they may be especially useful in patients who are poorly compliant with inhaled therapies. The other approach to interrupting the leukotriene pathway involves inhibition of the LOX enzyme itself. The agent xylutin directly inhibits lipoxygenase, thereby preventing leukotriene synthesis. To depict this, Coach LOX is about to get directly inhibited by our symbol for xylutin, a runaway Godzilla balloon set loose by some crazed Blue Oyster cultist. Because of a small risk of hepatotoxicity, xylutin requires monitoring for liver function abnormalities and is not recommended for routine use in mild asthma, hence our recurring hepatotoxic liver spot. Leukotrienes likely have an important role in aspirin-induced asthma. In fact, in 5 to 10% of patients with asthma, ingestion of even a very small dose of aspirin causes profound bronchoconstriction and systemic release of histamine. This can happen with any NSAID and is thought to result from the inhibition of COX-mediated prostaglandin synthesis, shifting arachidonic acid metabolism from the COX prostaglandin pathway to the LOX leukotriene pathway. See Coach Cox in the back there, enraged that it's not his team at the parade? Well, it seems the aspirin umpire is never too far behind and is inhibiting COX. Doing that COX blocking thing that aspirin do. This likely upsets the balance in favor of excess leukotriene production, leading to systemic allergic effects. Leukotriene inhibitors are very effective at reducing this response. All right, let's shift focus back to that step-up therapy I had mentioned earlier. Patients with mild asthma are usually started on a short-acting beta-2 agonist, or SABA, to be used when needed. Then, if asthma is still persistent, a low-dose daily steroid inhaler can be added next. If therapy needs to be stepped up again, due to suboptimal asthma control, the next step may involve the addition of a long-acting beta agonist, or LABA. LABAs are potent, selective beta-2 agonists, so we've brought in another beta-2 tuba formation. Agents in this class are salmeterol, represented by the synchronized salutes, as well as formoterol, highlighted by the formation chart. Again, these agents have that rol suffix common to the beta-2 agonists. These long-acting beta-2 agonists achieve their long duration of action as a result of high lipid solubility. Therefore, the bronchodilatory effects of these agents can last up to 12 hours or more. Our recurring symbol for prolonged serum half-life is a long tapering flag that depicts the significantly extended decay graph, this time held by the saluting baton leader. LABAs can be given as a daily controller inhaler and are always combined with a regimen of inhaled corticosteroids. Speaking of corticosteroids, besides adding a LABA, step-up therapy for persistent asthma can also involve increasing the steroid inhaler dose. So we've brought in another glucocorticoid moon facies balloon, this time a bit higher in the air. Alright, now that we've progressed to these higher steps for more severe asthma, I want to briefly mention another alternative therapy that can be added to a patient's regimen: theophylline. Theophylline is a naturally occurring methylxanthine compound related to caffeine, so we've incorporated it into a huge inflated energy drink. The name of this commercial beverage is xanthine to remind you of the methylxanthines, and the tagline, "You'll be flying," trademarked by the way, should remind you of the name theophylline. Theophylline works to increase intracellular cyclic AMP by inhibiting its breakdown by phosphodiesterases. As depicted by the advertisement in the back, the words "don't foster disinterest" should remind you of inhibiting phosphodiesterase, and the unusually direct message to go camping should remind you of increasing cyclic AMP. Increased intracellular concentrations can aid in bronchial smooth muscle relaxation, as well as the inhibition of cytokine release. Of the xanthines, theophylline is the most effective bronchodilator. It relieves airflow obstruction in acute asthma and reduces the severity of symptoms in patients with chronic asthma. It's also administered orally. How convenient. Here's the thing though. Once a mainstay of asthma therapy, In the advent of safer, more effective treatments, theophylline just isn't used as much anymore. Theophylline has a narrow therapeutic index and can cause numerous side effects. In fact, blood levels must be monitored because toxicity can be fatal. When thinking of adverse effects of the xanthines, just think of all those potential side effects of caffeine. These include central nervous system effects such as nervousness and tremor, not to mention numerous cardiovascular effects such as positive chronotropy and inotropy. This is depicted here as this kid hopped up on xanthine checks his outrageously high pulse. Theophylline is metabolized predominantly in the liver by the enzyme cytochrome P450, so in comes our recurring symbol for cytochrome metabolism, a CYP450 license plate attached to a chrome bumper. Remember, other drugs that can alter the activity of these enzymes can affect the metabolism of theophylline. Alright, on to our next agent, omalizumab, a monoclonal antibody specifically designed to prevent the activity of mast cells. At Sketchy, our recurring symbol for mast cells is a beehive, just waiting to degranulate and release some allergy-inducing histamine Bs. Remember that mast cell degranulation and upregulation are important factors in the pathogenesis of asthma. Classic allergic asthma is mediated by IgE, produced in response to exposure to foreign antigens. IgE will be represented by the IgE-shaped gun wielded by our fugitive here. Once produced, IgE binds to high-affinity receptors on mast cells in the airway mucosa, so when you're re-exposed to the same antigen, it triggers mast cell degranulation as well as the synthesis and release of other inflammatory mediators. So he shoots the mast cell hive with his IgE gun, activating histamine B release, in an attempt to disrupt the parade and escape during the ensuing confusion. Not so fast there, Dr. Kimball, because in comes our symbol for omalizumab, a limousine. It's the limousine of our US Marshal here who points an IgG gun while grabbing onto that IgE gun. That's because omalizumab is a monoclonal antibody directed against IgE. Take a close look and you'll notice that he binds to the Fc portion of the IgE specifically. In other words, omalizumab's specific target is the portion of IgE that binds to mast cells, preventing mast cells from getting sensitized in the first place. Omalizumab is intended for asthma patients with moderate to severe persistent asthma. Also, because of its unique mechanism of action, its use is limited to patients with evidence of allergic sensitization, demonstrated by a positive skin test, for example, and these patients usually have substantial circulating IgE levels as well. There's one other agent that works on mast cells, cromolyn sodium, represented by the chrome smoke dispenser used by Lynn's bee control. To calm those bees down, cromolyn doesn't influence bronchial constriction directly. Instead, it inhibits mast cell degranulation, preventing the release of pro-inflammatory mediators. Once widely used as a prophylactic agent in young patients with allergic asthma or exercise-induced asthma, it's now been largely supplanted by other therapies such as inhaled steroids and leukotriene inhibitors. Alright, before this asthma parade comes to an end, look up. We've got a few escaped balloons that are going to represent the emergent treatment strategies for an acute asthma exacerbation. Let's say a young patient has just arrived at your ER from soccer practice and is not looking too good, definitely in need of some immediate bronchodilation. What do? Well, the inhaled short-acting beta-2 agonists, such as albuterol, are the mainstay of emergent treatment of acute asthma exacerbations. Notice the beta-2 tuba. Systemic glucocorticoids are also added if the symptoms of airway obstruction fail to resolve after the first treatment with a beta agonist. Though children with severe exacerbations should receive systemic glucocorticoids as soon as possible. Remember, systemic therapy requires oral or IV administration, so we've included our recurring IV behind our glucocorticoid balloon. And about that cat IPRA pillar, nebulized ipratropium bromide can also be added when symptoms are severe. Recall from our Atropine in Wonderland sketch that ipratropium is an anticholinergic agent that provides bronchodilation through smooth muscle relaxation. One more agent to keep in mind, the rapid subcutaneous or intramuscular administration of epinephrine can also be helpful for children with severe exacerbations, or those who have a suboptimal response to initial aerosolized therapy. Recall from our epic summer camp sketch, that epinephrine is a potent alpha and beta activating sympathomimetic. This is especially when administered at high doses. Well, it's that beta 2 mediated bronchodilation we're looking for. Using epinephrine to treat asthma? That's pretty epic. All right, let's recap this phantasmic parade step by step. When managing chronic asthma, you need to consider both bronchodilator therapy, such as inhaled beta agonists, and anti-inflammatory therapy, such as an inhaled steroid. Beta 2 selective agonist drugs, represented by the beta 2 tuba players, are the most widely used sympathomimetic agents to treat the bronchoconstriction of asthma. Short-acting beta 2 agonists, or SABAs, such as albuterol, are your acute relievers of asthma symptoms, your rescue inhalers. If asthma symptoms persist, then add on low-dose inhaled steroids, represented by the glucocorticoid moon phases. These are your daily controller inhalers used to block this cellular inflammation process. Watch out for oropharyngeal candidiasis, though. Alternative regimens may include agents that inhibit those lacrosse-loving leukotrienes, endogenous compounds that normally mediate bronchial constriction and neutrophil infiltration. The inhibitors are represented by Monty, the montelukast broadcaster, who directly blocks the leukotriene receptor. Doink! And Xylutin, the runaway Godzilla balloon, who directly inhibits the lipoxygenase coach. If therapy needs to be stepped up again, long-acting beta-2 agonists, or LABAs, can be added, represented by the salmeterol solute and formoterol formation. You can also increase the inhaled steroid dose. Again, alternative therapies can involve the caffeine-like methylxanthines, which increase cyclic AMP by inhibiting its breakdown by phosphodiesterases. Other agents particularly useful in allergic-type asthma include the omalizumab limazine, which binds to the Fc portion of IgEs, and chromalin B control, which directly inhibits mast cells. Oh yeah, and one last tip. If you're watching a parade, make sure you stand in one spot. Don't follow it. It never changes. And if the parade is boring, run in the opposite direction. You will fast forward the parade.